UTI in pregnancy. So UTI is defined as the presence of at least 100,000 organisms per milliliter of urine in a symptomatic patient, or more than 100 organisms per ml of urine with accompanying pyuria. That is pyuria that will be defined by greater than 7 WBCs per ml in symptomatic patient. So the key thing to note here is you have bacteriuria in addition to the patient being symptomatic. So asymptomatic bacteria is the presence of more than 100,000 organisms per ml in 2 consecutive urine samples in absence of declared symptoms. So it is recurrent cystitis. Recurrent cystitis is greater than 3 episodes of cystitis. Etiology. The more common etiology is the KIP, that is the E. coli, which is the most common, Klebsiella, Proteus, and Enterobacter species. Clinical manifestation. These are simple. You have dysuria, increased frequency, increased urgency, suprapubic pain, hematuria, and pyuria, as you have defined it previously. In addition, you can have upper involvement of the urinary tract, that is pyelonephritis, and you'll have symptoms such as increased high temperatures, shaking, chills, anorexia, vomiting, costovertebral angle tenderness. So the workup that you're going to do, you obviously start with the lab. The common lab that you do is CBC. Then you do urea, electrolytes, creatinine, urine studies. You can also do, on the urine studies, you do culture, urinalysis, and dipstick. So urine is the specimen that you use, and urinalysis and culture is done at 12 weeks of gestation or the first prenatal appointment, whichever comes first. Management, you have behavioral practices, surgical treatment, and medical treatment. Behavioral practices, these are most commonly the hygienic practices. That is, we make sure the genital area is clean, and hygiene practices. So surgical treatment, these are rarely indicated. This includes cystoscopy, which is used for diagnosis, and retrograde percutaneous nephrostomy tube. This is when you have upper UTI, mostly to relieve obstruction. Medical treatment, it can be divided. It's either patient is asymptomatic, recurrent cystitis, or pyelonephritis. So asymptomatic bacteria or cystitis, you treat using nifrantoin 100 mg BD or amoxicillin 850 mg or amoxiclav 500 of 500 and 120 mg TDS, both for 5 to 7 days. Kindly note, this is one among the in pregnancy you treat asymptomatic bacteria, while in a normal UTI of a healthy patient you don't treat asymptomatic bacteria. Recurrent cystitis, you give prophylaxis, that is nightly, nifrantoin 100 mg or CEF 150 to 250. Pyelonephritis, you give ceftriaxone, and if the patient has board after the culture, they have the ceftriaxone is the one which is board spectrum, and if the patient after the culture they have resistant Enterobacter, you can give carbapenem 10 to 14 days. So pyelonephritis, these are just keynotes to note when giving or treating the pyelonephritis. IV administration of the antibiotics is given until the patient is febrile for 48 hours. IV fluids are given obvious to avoid dehydration, because you have indicated that the patient will be having nausea and vomiting, but also know that the patient can if you over dehydrate, the patient can have pulmonary edema and acute respiratory distress syndrome. So fever, as we indicated, you treat with acetaminophen. If the fever persists greater than 24 hours, and urine and blood cultures should be repeated, and a renal ultrasound should be performed. Antiemetics you can also give. Preterm labor and delivery, additional risk associated with pyelonephritis, so you give tocolytics. However, if the patient is in sepsis, you don't give tocolytics. Drugs that you don't use during pregnancy, the first drug is tetracycline. The reason you don't use it is because it affects fetal teeth and bones. Fluoroquinolones in pregnancy and lactations are not used because they affect the development of cartilage. Trimethoprim sulfametazole, they're not used in first and third trimester. This drug is commonly used in UTI. You will note that, as you have discussed before, that you have not used this drug, and the reason is that you don't use it in the fast and that transmitter, because in the fast it is a folic acid antagonist. That is, during the first semester there's oogenesis, and in that semester it replaces bilirubin, and it can cause a neonatal jaundice and predisposing the child to